to treat with FDM, or are there some challenges that you have in the clinic?
Fibromyalgia can always be very challenging because there's lots of layers. Sometimes there's lots of emotional layers that tie into it. I see other people have problems sometimes with plantar fasciitis, that it might not always be like the culprit, the origin of it might not be in the heel. It might be from something up above in the low back, something in the pelvis that might be driving the problem.
And on this topic, I have a question to you, because a lot of times the critic in the seminars about fascial distortion model is they always tell you, you don't look for other things. You only treat where's the pain, and that's it's a reduction of everything. You don't see the whole body. And what do you say to this when people come up with this? And how do you find that there's a connection to another region? You talk to the patient, or how do you deal with that?
It just depends so much on the different patients, but so I see it sometimes, people have a problem, it's not getting better. It's much easier if they've already seen an FDM practitioner. If it's, say it's plantar fasciitis and they've been working on CDs in the heel, if that hasn't gotten it, well, obviously that's not the origin of the problem. So sometimes you can get it just out of the history that they've done so much work on it already that obviously throwing more at it isn't going to get it better.
But how do you find another spot which you treat? You go by palpations, or you make clinical tests, provocations, or you ask the patients, do you feel there's a connection maybe to your hip? How do you find out there's a connection to another spot?
So on those, some of it comes from the orthopedic training that I had. So it's looking at what else is going on in the body. So then I would say it's not FDM sometimes in how I find the culprit, but then it's FDM once I find the culprit and work on it. A lot of times the sacroiliac joint is where I go to. Okay. And I find a lot of stuff tied to that. So once I get there, then I'm going to use FDM for treatment. But maybe how I got there wasn't necessarily thinking in the model. The patient didn't show anything at their SI joint, but maybe working there will help all the way down to the foot. Okay.
But don't you see in your clinic that when you touch the patient, or when you make some clinical tests of another region, a lot of times, or I think most of the times, when you touch there where's a painful spot maybe or something, it comes out of the patient that he tells you, you know what I thought? I always thought I'm limping or whatever,
Yeah,
don't you see that?
Yeah, sometimes you do find stuff that they didn't show, but you do find stuff sometimes that it is painful, it is a problem, especially higher level athletes. Like it might not bother them at the time. Okay. You have to remember, at mile 20 on my run, this thing comes up, and you have to go searching around for it because they can't find it.
Yes. But actually, I see an athlete, and there you have some dancers too. Yes, I see they have quite a good body feeling. Yes, they have quite a good idea of what they need. Yes.
Yeah, the ballet dancers are very good at figuring out what their problem is.
Yes, and that leads me to another question. That what do you think is the biggest difference from the fascial distortion model to other models, or to not because nobody says it's a model, yes, but to other methods or methods in manual medicine or in surgery? What do you think it's the biggest difference?
The biggest difference is the patient is the expert on showing you where it's at. So most of the time, they just show you the problem. You go to it, you know exactly what to do. So they've shown you where, they've shown you how by their body gesture. And I don't know any other model that does it like that.
Yes, exactly, yes. Did you see the lecture of the first translator of Dr. Tupaldos in Vienna? No, there was a symposium in Vienna last year.
No, I didn't see that one.
I think they put some online. I saw this one. And he said, that Dr. Tupaldos, he wasn't so much interested in fascia, actually. He said, he would say after all these years working and translating him, and he visited him too in Bangor. After 2 days, I think, his children, he took his children, they found out he had some big snakes near to the bed, you know, in some terrarium, but he had some covers on it. And he said that he mentioned 2 characteristics. I found this very interesting. He said solution-oriented in combination with patient-oriented. What do you say to this? I thought that was pretty smart from him.
Yeah, and solution like being immediate, like immediate results. Where there's a lot of things I was taught to do where we don't see like an immediate benefit. We expect it's going to take a while for the results to come along.
But I not mean subjective benefit. I mean objective benefit. If you work like I can osteopathy, you see immediate effect like, okay, the pelvis is okay now wait 4 weeks and your shoulder pain will be gone. Or your liver is in the right place or whatever, or your stomach, and then you have to, you know, it's also solution oriented. Or if you see an orthopedic surgeon, he will tell you, oh, now I fixed your meniscus, there was some stuff flying around, I just took it out in the arthroscopy, and now you have to just recover, wait for 4 weeks, yes, and it will be gone. Not subjective, objective, yes?
Right, yes.
But actually, I think it was pretty good what he said, because actually we are the only ones who are interested in what the patient says, how he feels. You know, after surgery or after craniosacral therapy or whatever, you know, everybody says, I fixed something and now it will be good. Yes?
Right.
But nobody asked.
Yeah, the practitioner always seems to be the expert, but in FDM, the patient is the expert.
Exactly.
That's something I love. And then patients love it when they get empowered to be in control and they recognize it's how they feel, it's how they're moving, it's their strength, their function. That's the important thing. It's how they feel about it. Not if I think it's better or not. It's what they feel.
Yes. And, you know, we talked about this last time, that we see now in Germany, as we have a lot of seminars here, we see a lot of people now who cannot, you see it really in the faces of the students, they cannot change their thinking. They think they are visiting another seminar. They are not thinking that they're visiting a different seminar. Yeah, and I'm always wondering in my seminars how I can get this point across, that we are doing really something different, not just another manual technique. You know, the thinking needs to be changed. So I'm always wondering, how did it develop? That we made somebody the expert like this. Do you have an answer to this?
It is a lot easier if you teach people when they're in school, when they're ready to learn and ready to, you know, be developed as a practitioner. It's a lot harder for some of the people that are well established in their careers and been out a long time, and they have been taught that they are the expert.
Yes.
That is hard to change. Now, some of them are readily changed. They're always looking to get better. So those practitioners, you know, they could be near retirement and they can still change like that because they want to always be learning and bettering themselves. Those are the easiest people to work with.
Yes, right. We have a lot of, or not a lot of, but some surgeons who are very pretty old. They don't give, they don't care about their career anymore. You know, they tell me, I just do what I like now, and I like this.
Yes.
One patient, I had an interesting talk with a patient this week, and he told me, you know what is interesting, that you call this model, and he told me, you know, because I never saw this in manual therapy. He went to other therapists and he said, I watched a lot of manual therapy or manual medicine methods, but he said, nobody tells you model. So he told me, in the moment, if you don't tell somebody it's a model, then you already think or tell to others it's the truth. And he said, I think this is the problem. We should call every manual method, we should put model at the end of each one of it. I thought that was always,
yeah, it's always theory.
Yes, it's always theory. And that if you don't do this right in the name, then every student in the seminar or every practitioner, he will think this is the truth now. So he said that's what he liked very much, that we put model in there, that we already have a different character. Yes.
Yeah. I'm seeing a bunch of people that have joined us. I'm wondering where people are from. I wonder if people can
Bettina
comment.
is from Switzerland. I see Mahmoud from Mashhad. He was there last time. I see Monica from Poland, but the rest I don't know actually.
Yeah, I wonder if do we have anybody from Africa? Anybody from Belize?
No, I got some.
Michigan. Okay.
I got some WhatsApp numbers from Africa, and I wrote to them there, and I invited them.
Mm-hmm. Hi, Aaron. Angela from California. Good. Okay, good. This
Excellent.
is nice to see where people are from.
There's a German student from near Cologne.
No, Armel from Belize. Excellent.
Hello. Hello to Belize.
Moscow, Russia. Sacramento.
Ah, our man from Moscow, from California.
Yeah.
We have quite a community, yes?
Yeah.
Russia, yes.
Russia. Excellent.
This is, you know, Dr. Gül from Istanbul. He's FDM instructor too. Hi, Ayhan.
Yeah. Istanbul, Turkey. This is great.
Yes, so he's instructor. We study together. With Georg.
Yeah. So I'm wondering if anybody of our people out there have any questions, have any cases that they want to go over, any techniques. So
Alaska even.
Yeah. Yeah. Yeah, Angel wants to go visit all these places. Yeah, won't it be nice when we can go visit all of our FDM friends again across the world?
Yes, sadly the Congress is canceled.
Yeah, I hope we can have it next year. It might be till November of next year to get it.
We should.
Yeah, we should create an FDM community to speak about some topics one time a month. Yeah.
Yeah, this would be nice. Yes, good idea.
Yeah.
Yes, we could do that. And maybe already during the next meeting, people could already write their topics.
Mm-hmm.
Yeah, I do this now in the seminars. I at the end of the presentation, I put my phone number on the screen, and everybody writes it down. And the students send me some WhatsApp videos, short WhatsApp videos of patients. I cannot see the face. And then I just do a screenshot and I give them back some advice or what I see, or I use this for myself as a training, and it's very nice to stay in contact with everybody. We could do the same here too. Yeah.
Yeah. So who wants to throw out a question? The topic.
Guys,
case.
Questions there, Matt.
Yeah.
Matt, the hardest case in my clinic, tennis elbow. Tennis elbow is challenging me at the moment.
Okay.
I treat CDs. Oh, there's a question now before we come for frozen shoulder.
Okay, frozen shoulder, see him twice a week for tectonic fixation techniques, making some progress, wondering what else I should think of. So with the frozen shoulder, what do you look at, Thorsten?
Oh, actually, I would say if the patient, for example, if the patient cannot move until here and he says it's just frozen, then I do a passive provocation, and a lot of times I see still trigger bands. And I see the tectonic fixation a lot of times as a protection for another distortion. So I think, but this is not only the shoulder, but I see a lot of times in the shoulder that you have to do a passive provocation, just a little bit, you know. But then I see a lot of times CDs, trigger bands, and first I see that trigger bands, it gets very fast. You have a trigger band for 2-3 weeks and the shoulder already becomes so stiff. And as Dr. Tupados wrote, I think the trigger bands, they block the fluid, you know. Like somebody can have a folding, but he has no problem in moving. But in trigger bands, I see this a lot of times. So then first I treat the trigger bands, and then they can move already better, more pain-free, the fluid is better, and then I start with the tectonic. Because a lot of times I treat a tectonic too early, and then the patient got pain. So the tectonic, sometimes I see is a protection.
Yeah, I see it, Angela, my response to that would be, I see a lot of CDs just on the joint line. So I think some of these people, they've had, like Thorsten was saying, they've had old injuries that might be protecting, but I see a lot of CDs all the way around it. So I end up just treating all the way around the capsule and almost like going back and forth, proximal and distal, all the way across it, doing the whole thing. And that usually makes a little bit more progress as well. That'll be more of a fast forward. Yeah.
Yes, and just Dr. Tupados wrote in his book, the patient cannot anymore, or you. It's just very exhausting to treat a frozen shoulder. And sometimes some physiotherapists, they come with the patients in my clinic. And then I see, because they treated them a lot of times, those patients, and they developed like a social connection. And then I see, if you have a little social connection to a patient who comes a lot of times to your clinic, then you start to do less. They talk more than work, really. Yeah. So I think in frozen shoulder, you have to be very strict. No, not much talk with the patient. Just work, 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 and every time challenge him again. Yeah.
Yeah. Yeah. And it's not pleasant work, definitely.
Yes, that's it. That's it. You actually, you're not. You will not become friends through the through the treatment. So there was another question about recurrent HTPs.
Justin, where are you thinking? Where do you see these recurrent HTPs at in the body? If you can comment on that. So, I definitely see the recurrent HTPs in different areas, upper traps. See them on the flank a lot. Where were you specifically referring to those, Justin?
And Harun, I saw from Turkey the other question about dynamic TB technique. I wrote it down. We will answer it after it.
Yeah. Okay. Superior cluneal region. Are you treating those with the patient down in the child's pose? Because I find like really opening them up in the child's pose will help to get that fully sunk down in. Trying to think of other things in that area. I mean, sometimes you also find there are lipomas in the area as well that are not an HTP, and those aren't going to reduce if it's a lipoma. But the child's pose or even sideline, I think I've gotten those to reduce further. Yeah. Oh, good. I thought of something you haven't tried. That's excellent, Justin.
That's good.
Yeah, and lots of force. I mean, there was a video somebody had out there that was somebody just hammering away on someone's low back, and I think that's gone around on the FDM groups. And I've joked with patients about that we just need some sort of, not a chisel, but some sort of blunt instrument to just pound those HTPs back in. But usually it's more of opening it up. So I find you might have to twist the body to really get the fascia to open, and then you can sink the HTP in and get it to close up. I find sometimes that they don't want to close. They've been opened up and they've been there so long that it's almost scarred and adhered into place. And so for those, you have to do a lot of trigger bands across to break the adhesions so that fascia will then close down over the hole. Yeah.
I think in general, HTPs are just difficult. I think it's, Georg once told me, and when I first did my first modules, I took some patients to the seminars when he was here in Hannover. And it was a lot of HTP patients. And he one time told me, you know, Thorsten, the older you get, the better your technique will get.
Right.
And there was one student, he studied with Dr. Tupados in Europe, Georg Grasser, and he came to my clinic for hospitation, and he found them and treated them so quick. He does it like, I think like 7-8 years longer than me, FDM, and you saw it really in his technique. Yeah.
Mm-hmm. Yeah, I think some of those, it's also finding like, you know, as it goes in, following the angle as it reduces, that it doesn't just go straight in, that it may almost wormhole to get to the right layer, to get all the way down. Yeah. So I see kind of a follow-up question on HTP since we're on this, just how we describe them to patients and if we give them any home treatment. So mine really depends on the patient. So I don't describe them necessarily. When I teach this, I say that most patients don't really care what it is. They just want it to be better. So I try the simplest techniques, like, okay, we're going to work on some spots here to make you feel better. And if they are okay with that, we move forward. If they seem a little bit confused or they need more information, I'll describe more. I say an engineering type of mind, someone that really understands structure and they have a need to understand structure. Then I'll start talking about, okay, we have a plane here, and something pushes through, so we're going to try and push that back down through the hole. And that's really needed to get it. And sometimes we need to really manipulate so it goes through. But I don't do that with most patients. I won't start with that. I'll only go to that if they feel like if I feel like they really need it. And it really tends to be that engineering sort of mind. A lot of other patients, they're like, okay, just make me better. I don't care what you do.
Yes, and that's what we talked about last time.
Yeah. And it's just easier that way, because you never know when some patient is going to have some fear about it. You talk about a herniated trigger point, and herniated, there's an association with a herniated disc, and like all this fear can be like, oh, so I try to get away from using those terms unless I really need to, because I don't want to instill fear, and I never know who is going to have that. So best to make it simple. I talk to them like they're, in elementary school. Yeah. And if they get it, then we move forward. Yeah. As far as, what were you going to say? Yeah.
No, it's good. Yeah, go ahead.
Yeah. For home treatment of HTPs, sometimes we use some tools, and we will tell a patient to use that. So they're like a novel toy, like something plastic. Patients will tend to use a tennis ball or lacrosse ball or foam rolling, and I say that's too blunt. That doesn't work. It's not deep enough, and you really need a thumb to do it. But if you get some sort of toy or tool that is more pointy, you don't want to puncture the skin, but it needs to be basically like a thumb. Then they can roll on that or push on that. Sometimes I will have them bring a spouse or bring a loved one in and do that. But then they get into the issues. If you have a loved one treat you, there's all the relationship issues. If it's a spouse treating you or a loved one, that is that going to ruin the relationship? Oh yeah, the back end of the plunger.
I saw some patients. He did like this. He put it on the wall, and he stood with his back against the wall. They can do it in here and here. They just have to be careful with the 12 strip. Yes. But actually, one patient, he found this out, and I think the size is very good, and this moves, so it's a universal tool.
Yeah, I hadn't thought about that. That's a good one.
I took it from the kitchen.
I saw another question on here. It was about the dynamic trigger bands.
Yes. Yes. I don't know anything about this actually.
So dynamic trigger bands, I'd say just a trigger band with movement.
So
that might be a good one to demonstrate. So Chris, do you want to help? I've got some helpers here. We might be able to, so we can do this one as a technique. It's just doing it with motion. So sometimes it can be for maybe more the athletes, where you just do it passive. You do it when they're laying on the table, and it just doesn't get the trigger band out. They need to be tensioned and under a load. So for a runner, it might be in their calf muscle and Achilles, but you need to do that technique when they're going through a motion. So was it with the, who had that question about the dynamic trigger band?
Oh, it was Harun. He's the last comment now. He's still laughing probably.
Okay. All right. So is there a certain area of the body that you want us to do this dynamic trigger band on? Let's see. Who wants to be patient? Be patient. Isn't that showing? Let's do you want to do a calf? Okay, let's do it with a calf. So let's see if I can do it here. I'm going to see if I can flip the screen around. Yeah. Okay. So let me move this. So Zach, if you want to get that one, and it might just be more unique. So the higher level athletes, I tend to see I have to do those dynamic ones a lot more to get the final parts of it out. So it might be the last 5 or 10% of treatment needs to be very specific for their sport, their movement. That'll really help. Yeah, that was a good question. Thanks for that.
Yes. And then we had the question about the dosage of the foam rolling. Hi, Andreas. There's one colleague from Switzerland.
Okay.
How about the foam rolling, Matt? Do you advise that if somebody wants to do this? Do you say, okay, you can do it this way, this way?
I don't advise much for foam rolling. I don't think it's worth it. My general recommendation is it's not worth the time. That it's too blunt, and it doesn't get into any of the tissues. It makes the tissue relaxed. It might feel better. So it's more like, you know, stretching can be good. That could be useful, but I don't see it as like a good FDM type of treatment. I do have a rumble roller. Zach, can you grab the rumble roller? Rumble roller, it has more bumps on it. That can be like a thumb. So sometimes that can get into a spot and could be a self-treatment for an HTP, kind of. It's obviously not as good as just one little spot going in, but sometimes that will help.
Mm-hmm. And there you see the patient question there?
Yeah, I have a patient that came, pain to the left side of the neck, motion was shown as a line with 2 fingers. So I said trigger band, but not getting any relief. So the thing, if they're showing, I'm assuming they're showing like this, showing a trigger band. If a trigger band there is not working, so the things to think about, if you've just treated in one direction, so you've treated from bottom to top, then treat the other direction as well. Then I also look for CDs at the endpoints. So, you know, what is this area that you're working on? Then you might find a CD at the top, you find a CD at the bottom, and then it might need to be treated in different directions, just like we were doing with this dynamic trigger band, that maybe just in one position, the trigger band doesn't work. Maybe the trigger band needs to be done with the body in a different position to get that to help. Yeah. Do you have anything to add to that, Thorsten?
No, yes. Actually, it's what what I see mostly in myself too, in the clinic. Yeah.
Yeah. Yeah. So the thing about the foam roller not working, when patients say, you know, oh, I was wondering about, you know, getting a foam roller, and I say it's a little bit like the Crocodile Dundee movie when he's getting mugged in New York, and he's saying, you know, that's not a knife. No, that's a knife. So a foam roller that has bumps on it, like this might actually do something. So I tell patients, like, this might get in a lot more effectively. Like, foam rolling can hurt, but it doesn't always like actually change anything in the long term.
Yes.
So, yeah. Let's see, there's other questions that came through. Oh, are we doing FDM with gloves on? No, I'm just washing like copiously and using hand sanitizer and hand wipes. And like if I touch the patient, I'm not touching anything else until I wipe my hands. I feel like I can't work through gloves really well. It just changes it too much. So I just assume that I'm infected once I touch somebody, and I have to wipe myself off and clean it before I touch anything. My computer's never been so clean. It gets cleaned a lot during the day. Yeah.
What I wanted to say also to the foam roller is, I see, I think or patients tell me there are some courses or they do some exercises in some fitness studios with foam rolling. Mm-hmm. And sometimes it can get patients relief in HTPs. But what they always do is when somebody or some trainer shows it to them, they always show them treat it in the position of pain, and that is very painful. So I think if you have like an HTP and you treat it in the position of pain, you make it actually very narrow. You just do yourself pain without any benefit of it. So I tell my patients mostly, you know, if you're addicted to it and you want to use it, do it in a position of ease, of release, you know, because then you will open and the pressure will give you more release. It maybe not fix it, but it's better to do it in a good position.
Yeah.
And with the trigger bands, I see a lot of times if you have a trigger band, you know, we do this with the thumb, but the foam roller is just rolling like this. So I see just some relief, but it never fixes the trigger bands, yes?
Mm-hmm.
But then if you want to have some relief, I tell them the trigger band in the position of pain. Yes, that's better because then you stretch it. That's just for the foam roller. So some people, I think, or some sports people, if you talk bad about the foam roller, it's like blasphemy already. You know, they're addicted to the foam roller. If they want to do it, okay, just do it, but do it in a way that you have more benefit from it. Yeah.
Right. I think the only time I've really recommended a foam roller is somebody that had a tectonic fixation. So they had it in their thigh, and we're just trying to get layers to glide and slide. So I think the foam roller then can help with getting that tectonic fixation. So that made more sense to me to use it in that situation.
Okay, yes, I didn't think of that. Yeah, that's true.
Yeah.
There's another question. Did you see this with the different distortion?
Yeah, about the cylinder technique for smaller body regions. I think that's a great time to do double thumb technique. Yeah. Do you know AK Reeves 22? I don't know who that is, but do we know the double thumb technique? Because that would be ankle, small areas on the foot. That's a perfect time to do it because it doesn't take much time or effort to do a small region like that.
There's a question about visceral or systemic disorders. What would be a systemic disorder?
Oh, it's Jen. Oh, sorry, Jen. I didn't recognize that handle. Yeah. Double thumb technique, Jen. Yeah, and Jason's saying that we did the double thumb on the stitched foot in Belize. Yeah,
okay.
I forgot about that. Yeah. So yeah, let's talk about the one with the effects on visceral, systemic disorders. What do you say to that, Thorsten?
I didn't get the question. Systemic. You have to ask back, what is a systemic disorder?
Yeah, Harun, what sort of systemic disorder were you working about? Asking about
actually, I think maybe if I understand the correct question correct, then actually if I think in fascial distortion model, the model has to be so good that I can explain everything by the model. So Keisuke Tanaka said it very clear in a seminar in Japan. The diagnosis is wrong, the technique is bad, or no fascial distortions. These are the three possibilities that we have. Yeah, so maybe my diagnosis is wrong or my technique is bad. Then I have to work on myself. But sometimes we are working with hands. Sometimes the distortion is deep inside, or there's a tumor or something where the biochemical factor is just bigger than the manual effect that we have. So then we have to find another way to do this. Yeah, sometimes, like for example, patients with borreliosis or something like this, the pain jumps everywhere in the body. Then you can treat cylinder and just help them for the moment. But there's a biochemical factor. Well, I don't know any medication for fascia so far, so maybe there will be some coming up. I think the model will still develop. Yes. Yeah,
and for visceral, I see just abdominal area. I see patients that have scarring, like whether it's from injury or from surgery. So I see trigger bands, HTPs, and obviously you just have to be really, really careful that you're not putting any pressure into organs that don't need to be pushed on, but you can usually work into those. And we had some of those in Belize 2 years ago as well, where we had an HTP that been painful for a couple of years, and we popped it in and just done, nothing left. They thought it was voodoo magic that it had gone in so well that, yeah.
Yeah, that's the big chance if you look on it from a different point of view, yes.
Mm-hmm.
There's another question. You see this one with a chronic knee pain?
Yeah, chronic knee pain, reduced range of motion, multiple meniscus injuries, no surgery. Treat the obvious distortions, not sure if there's a folding or tectonic. Yeah, and so if it is a reduced range of motion, that can be part of the tectonic there. The other thing is when there is reduced range of motion in the knee, often there's a posterior CD, a posterior knee CD, popliteal CD, and they might not show it. So they're not giving a hand gesture for it, but you have to search around in the posterior knee, careful with the vasculature and the nerves and the back side of the knee. But a lot of times on that joint line medial and lateral, you can find CDs there, and that will help the knee flexion improve significantly.
Yes. And there was another question about how you determine the direction of the folding. It was a little bit before.
Yeah, how to determine the direction of the folding distortion. So the way I teach that is if you're listening to the history, then you've probably heard about it, the mechanism of injury. So you know whether it was a traction injury or a compression type of injury. So that should tell you. But sometimes people don't remember, or they, if they had a fall, they might have had both unfolding and refolding. So the best advice is get the folding distortion technique set up and try one and see how it feels. Recognizing foldings don't hurt to treat. So if it hurts, you back up and you do the opposite direction. If it still hurts, you probably have one of the painful distortions to clear out. So you still have a CD, a trigger band, an HTP. Clear those and then go back to the folding distortion again and try compression or traction. And sometimes both of them could work. And so you can do either one. It doesn't matter which one.
Yeah, or the patient tells you, I'd like to shake my hand, or it's better when I lay, or whatever, It depends on daytime sometimes in the back too. It's better what is, yes.
Yeah.
They did the other question about the HTP in the calf.
Yeah. So the difference between a small cyst or an HTP in the upper calf. So a small cyst won't disappear when you push on it, but an HTP would. So that's my smart aleck response. HTP will get better. And the cyst
I didn't
won't.
see an HTP so far. So.
Yeah, I do see those in the upper calf, and often right where the nerve and artery is piercing down through the gastrocnemius. So there are HTPs there, but they will reduce easily. I don't often see cysts there. Cysts in the body, sometimes you can work around a cyst. So let's say this is the end of a cyst. If you work around it and not on it, you may be able to break up some adhesions around it, or sometimes it's just, it's almost like plastic that's been glommed together, almost like you're heat sealing a freezer bag. And if you do CDs around the edge of it, you might break it apart and it might get resolved and absorbed by the body.
That's a good answer. I have problems. I have to admit I have problems when they come here, I treated CDs, trigger bands, but I have to admit I had some patients. For a moment was okay, but it always came back. Yeah,
and the cysts that I've worked on, I tend not to push into the cyst. I push all around it. So I do CDs, and it's almost like I'm breaking up all around on the edges of the cyst, and then sometimes then it opens up and it just goes away. So by the next day, it might be resolved. Yeah.
So Matt, what do you see to those two, Terra guns or something that everybody has now?
Oh, say that again.
What do you think about those Terra guns, or how they are called? This thing.
Yeah, the Terra gun. Yeah.
Yeah. What do you say to those?
Those make sense to me. So Dr. Capistrant uses those from Fairbanks. I think it makes sense to change the tone in the area. So if you do that first, so say you have a really stubborn HTP and there's just a lot of tension and it doesn't allow it to really open up enough to reduce, then I think you do all that vibration and it loosens things up, it softens, and that make it easier to reduce those things. I think that's how they can be beneficial. I don't think they're like really good, like it's not the same as a thumb for reducing the HTP with the gun itself, but I think it's a good preparation for a technique.
Okay. And he uses it only for HTP, or he uses it for another distortion? High volatility.
That's how I would use it. I'm not sure if he had other things he was using it on. I mean, yeah, I'm trying to think if you could do like a deeper trigger band for it.
Mm-hmm.
Might be
okay, but
maybe like a dynamic trigger band could be used for that as well. I'm just kind of thinking out loud with it.
Okay, you don't use it.
I don't use it. We did some in the family medicine residency. We do have it over there, and we've used it more as preparation for doing the HTPs. Yeah. Justin, did we answer your? Yeah, I was going to say Justin's question. Did we answer that about the Baker cyst? The idea of just doing the CDs around it? Yeah, and then Roman asked about the CD. So Roman, are you asking about using the Theragun and doing that, tapping on the CD? Okay, good. We answered Justin's question. Yeah, I don't know if it would work all that well on a CD. I just think more specific pressure is better rather than the tapping. Again, maybe if things are really tight and you can't get to it very well, you're not getting very specific pressure. Maybe that would help if it's very deep in the body and you need to get more depth into it and more specific. That's where I think the Theragun would be helpful, is preparation in very tight areas where you just can't get specific enough. You can't get the precise pressure with it. That would be my use for it.
Yes, there's another question. Did you see this, Matt?
Yeah, sequence for treating distortions. Yeah. Painful distortions first. Cylinders last. So between trigger band, HTP, CD, treat in the order that the patient shows you. I think there's slight differences from practitioner to practitioner on which they treat of trigger band, CD, HTP first, but then you move on and do fold-ins, tectonics, cylinders. Cylinders last, unless that's all they show you is cylinders, then you could start with it.
What do you say to the cam impingement question?
Yeah, so I'm just reading this now. So I don't see any progress in surgery with cam impingement. My FDM treatments don't lead to an improvement. So maybe the diagnosis doesn't fit to FDM because of the pathogenesis.
Well, first we have to say.
So my thoughts on that. I think sometimes there's a folding distortion with those cam impingements, and you just have to get enough of the painful distortions out of the way around the joint. So do the CDs, trigger bands, HTPs, and there might be a big fold in there. Yeah, and it might be a big refolding sometimes that needs to be done, which seems odd, but if you get those released, I've seen those things change more.
Yes, and I saw it, and this is a lot of times. I now had a patient, and the osteopathic interpretation is always the iliopsoas, And this patient, I always ask myself, why do my runners, why do they have pain when they run? Because I always thought they have compression, but why they do have pain in their refoldings? And then one guy, he was at my clinic, and he asked them, when do you have the pain? And they have the pain not in the moment of compression, but in the moment of release. And then this patient showed too, she showed it in the moment of release. So it seems to be, if you have a refolding in the hip, I now remember this patient, and I saw it in the ankle too. You first have compression, this is good, and in walking or running, whatever, then you have a decompression, and then you have the refolding pain. And if they cannot fix it by their own body weight, so it must be a very, very exotic kind of angle that you have to refold this.
Right. Yeah, I agree. I see a question about dry needling in FDM.
Now we had this last time.
Yeah, I don't do dry needling, but two of the therapists in my clinic that do FDM do use dry needling. And the way I look at it is if this is the fascia and you get a needle into it, you can twist it up and the fascia will pull up with it. So I think if you have an HTP, you could be pulling on the fascia. So let's say you get a needle in next to it, you could pull the fascia up over an HTP and relatively reduce the HTP by pulling the fascia around it. That might help. And then you could be working on tectonic fixations. If you have a really good needle, like a very small CD, needling could get into a CD and reduce it that way. I have some physician friends that do injection techniques, and they will go in and with a point of the needle, they're really jabbing into the bone. So they're reducing CDs with the tip of the needle. That's not dry needling, but it is still in the model. And they've thought about it that way, that when they poke so hard, like doing prolotherapy, trying to, injecting like a sugar solution to irritate it, they also irritate it with the tip of the needle, but they reduce CDs as they inject.
Then there was another question from Harun, if there are any universities. So now that I went to Tehran, they, as like in Turkey, where you are located, as it is academic profession in Iran too, they do a lot of studies at the University of Tehran. So you can exchange with them. I don't know, or you contact Dr. Gülük. I don't know if if he's doing something in Turkey, but I know now at the university, at the Tehran University, they do a lot of studies. So that would be an idea.
Yeah, and I think there will be more universities in the U.S. doing research. I don't know specifically right now which ones have anything going on.
In Germany, it's not academic, non-academic.
Yeah. The Cleveland Clinic and the Mayo Clinic in the U.S. have some things going on. I don't know where they're at in the process. In Pacific Northwest University, the Osteopathic School in Washington State, they have they've had some stuff on ankle sprains that have been going on. I don't know where that is in process right now. Aaron had a question. SI joints implicated for distortions of other regions. Is there more SI instability or immobility? I see it as instability, or I'd say hypermobility. I see a lot of hypermobility in the SI joint, the sacroiliac joint. I think a lot of people have just injured it with falls, with bending, women with pregnancy. It doesn't always get as tight afterwards. So I do a lot of CDs on the SI joint. That's probably the number one thing that I treat in the clinic is the sacroiliac joint.
Continuum distortions.
CDs, yep. CDs on the SI joint.
Yes. And it's the same, you know what, Aaron, what you are talking about is some objective finding. But this is difficult sometimes to mix, you know, if the patient has no feeling for it. So actually when you treat the CDs, then a lot of times some emotions come out of the patients. They become very emotional because they feel this connection only when you touch them. And before they do not feel this. But I'm very careful. We had, you know, I come from osteopathy school and we had this joke that what I told you last time, what is the difference between God and an osteopath? And it was like, God knows he's not an osteopath, yes. And that's it, you know, because then we start, you know, to become smarter than the patient. It's the same if we tell everybody where the trigger bands go, you know, then we become smarter than the patient. So I think we have to be careful with those kinds of things. But when you treat the CDs, the patient knows this is the spot, what needs to be treated. And this should be more leading than objective finding.
Yeah. Yeah. Justin had a question about trigger band through the knee. Basically like a trigger band that goes through the body, you get both ends of it and then you wind it up, you twist until you get tension. Sometimes you can push through it, or sometimes you just wind it up and hold and it'll release. How do you know when you've got it? So you'll get emotional. There's a little tear, you get warm. You know, sometimes you don't know, Justin, until you try the treatment. Maybe you feel a little release. and then you stop and have them recheck their motion. Whatever their movement was, you recheck it, and they'll tell you if it's better or not. So sometimes it's so vague, it's so deep, you don't get a good sense of the change. It's not like a superficial trigger band. So it's a little bit of guesswork, and then you recheck. And I think that's where FDM is so great. You get that immediate recheck, and then they can tell you, is it better or not, if you need to do it again. I've had some of the deep ones where the patient does actually sense that shift. They sense that it's done, and they know it. Majority of the time, I think it's vague enough. They're not quite sure, and then we just recheck it and see if it's better. Another question there. Have you ever seen a one-sided lumbar folding? Absolutely. Yeah. Yeah. Left side, right side, anterior, posterior. You can definitely have those. Think of the way the injuries are. You can definitely have those. I think positioning the patient correctly is the key to getting those, to make sure you can reproduce the mechanism of injury in a safe environment.
And then there's the question, why FDM does not do diagnosis of the joints? Why? For what reason? You know, it's the problem that, as I said, with the SI joint, you know, we don't want to be smarter than the patient. So anatomy is not a reality. It's just a form of communication. And we have to be careful just to see that FDM is really different and not another thing. And just don't try by force to put it into your old truth that you know already. You know, open yourself up to something new. And that the anatomy is always the anatomy of the anatome, not of the patient. And we follow the anatomy actually of the patient. Right.
Yeah, the only time I'm using that is like if I'm communicating back with the orthopedic surgeon and I just want to put it back in their terms. Or
form of communication, yeah.
Yeah, or that engineering type of mind in the patient where they're dissatisfied with me talking to them like they're a third grader, and they need something very concrete. I'm like, okay, well, this is kind of like a sprain of the medial collateral ligament, and you know that makes them feel better, but it doesn't matter because I need to treat the CDs, the trigger bands, the folding.
Yeah, that's it. That gives you actually you just go towards the patient. You take him where he stands, you know.
Mm-hmm.
Yeah.
There's a question, how you treat if it's an old injury.
How you treat is an old injury.
Yeah. All right,
actually, time doesn't matter so much in FDM. Time only matters in the trigger band. You know, it's like if you meet with old friends from school. You see, sometimes time does something and sometimes time doesn't change anything.
Right.
And I see the only thing where what changes something is the trigger band. Every other distortion doesn't change so much during time.
Mm-hmm. Yeah, I think with the foldings, what are you saying? Like if it's an old injury, there might be more layers on top of it. So you have the original injury, and then the body has more and more distortions over time, maybe from compensation patterns, trigger bands, gain adhesions. You get that chronic trigger band. So that makes sense. But sometimes it really doesn't matter. You can get it. I had one patient, it was 50 years since their injury. They were a 70-year-old person. It was low back pain, and they were showing an HTP. It was in the flank, and it took 2 sessions to get enough trigger bands done around it and loosen it up. That on the 3rd session, we'd been trying for the HTP, but we couldn't get it. And then 3rd session, it was loose enough. Then we got it. And
okay, Matt, I have to call you back. We have only 5 seconds.